FGFR alterations occur in patients with cholangiocarcinoma, and we are fortunate to have now two drugs that are FDA approved. Unfortunately, resistance is common, and therefore we are looking for a next generation of FGFR inhibitors to target resistance. Tinengotinib is a next generation FGFR 1 to 3 kinase inhibitor, which is recently being investigated in a clinical trial. It targets FGFR in a unique mechanism because it binds away from the ATP binding domain with strong affinity, and it also targets the kinase domain mutations which lead to resistance. So we included 55 patients in a clinical trial who were enrolled in 4 cohorts. The study was primarily targeted for cholangiocarcinoma patients with FGFR alterations. Cohorts A1 and A2 included patients who had FGFR alterations and had received prior FGFR inhibitor therapy and had progressed. These cohorts included primary resistance and acquired resistance. Cohort B included patients who had FGFR aberrations other than fusions, such as mutations and amplifications, and cohort C was the wild-type FGFR. In terms of results, the drug was dosed at 10 milligrams daily and generally well tolerated. Most adverse events were grade 2 or 1. However, there were some toxicities noted, which included hypertension, diarrhea, stomatitis. These were, for the most case, manageable, but 30% of patients required dose modification. In terms of results, overall, for the FGFR altered cohort, the response rate was 26%. When we looked at patients who had FGFR aberrations and had progressed with prior FGFR inhibitor therapy, that cohort, the response rate was 40%. And in the wild-type cohort, we didn't see any responses, but we saw some stable disease. The progression-free survival for the FGFR altered cohort was a little over 5 months. And for the FGFR altered patients who did not have any prior therapy, such as with mutations and amplifications, the progression-free survival was 8 months. These promising results have led to a phase 3 trial of Tinengotinib versus physician's choice for patients with FGFR altered cholangiocarcinoma that have progressed after prior chemotherapy and FGFR inhibitor therapy. The endpoint of the trial will be overall survival. This study has already been initiated and is enrolling. Tinengotinib is effective in case of FGFR altered cholangiocarcinoma because it has a unique mechanism. The current FGFR inhibitors bind to the ATP binding domain, where resistant kinase mutations occur. Tinengotinib binds away from the ATP binding domain, so therefore is less subject to resistance from these acquired mutations. Also, the binding affinity of this drug is very strong. So I think for all these reasons, this drug is effective in case of FGFR alterations. At the current meeting, ASCO GI 2024, there is another poster which includes Tinengotinib in combination with atezolizumab. So we do believe there is a potential for combinations such as with immunotherapy. The current treatment paradigm includes chemotherapy and immunotherapy as a standard first line for patients with cholangiocarcinoma. Now, for patients with FGFR alterations, can they be targeted with specific FGFR inhibitors rather than chemotherapy? This question will be answered by 2 ongoing trials, one which includes pemigatinib, and this trial will, when completed, will indicate whether FGFR inhibitor therapy is an adequate substitute for chemotherapy in this setting.